RCTs on the clinical management, as we know that there are many studies and the data is coming from the high-income countries, but the majority is trauma is still in the low-income countries. So we would like to see how we can apply all the findings of different studies, and we can also apply the findings of RCTs, and all together how we can improve the global TBI management. And now I would like to request Bart to go ahead. Thank you very much.
Thank you, Ifti, and thanks for organizing this. It was a brilliant idea, I think, to organize this webinar on the implementation and the relevance of studies and RCTs on our management and on guidelines. And we're happy to have three eminent speakers here with us. First, Professor Tariq Khan from Peshawar in Pakistan, who will talk about the implementation of research findings in low resource settings. Professor Peter Hutchinson from Cambridge, who will talk about RCTs and what they mean for the guidelines, and Professor Franco Servade on what the evidence actually can bring about in TBI management in practice. Maybe two household remarks. We will start with Professor Tariq Khan because he has to leave a little bit earlier, and we will take the questions for him immediately after his talk, before we then move to Professor Servade and Hutchinson. I myself will have to leave at 6 p.m. because I have a flight to catch to get back from Helsinki to Belgium. But Ifti Hossain will be happy to take over the coordination at that point. So please, Professor Tariq Khan, the floor is all yours.
Thank you, Bart. Thank you, Ifti. Thanks to EANS for organizing such a important topic. It's a very difficult topic also for somebody from LMICs. I just want to basically say something which you all know, that TBI is a significant public health concern globally, especially a high burden in lower and middle income countries because of road traffic accidents, because of falls, and because of violence. Yet evidence-based TBI management remains limited in low resource setting. We know that RCTs are the gold standards for getting high quality evidence, and it's essential for that. However, conducting RCTs and LMICs has got its own challenges, especially because of low resource settings. But we know that RCTs have a great future and have a great potential. The fact that majority of the population resides in LMICs, yet although it's very difficult to know, as there is no up-to-date data to know which RCTs are coming from low income and which from high income. But by and large, what we know is that the majority of the randomized trials are coming from high-income countries, and there's limited high-quality evidence to inform TBI management tailored to LMIC contexts. Obviously, we all know this, that existing literature indicates a significant disparity in the volume of TBI research between high-income countries and low-income countries. And sadly, very little is known about patient outcomes after traumatic brain injuries in LMICs. Just an example, that a systematic review analysis analyzing prognostic models for TBI found that only 7% of the 102 models reviewed were based on data from LMICs, highlighting the underrepresentation of these regions in TBI research. In contrast, and we're talking about the current status, obviously, that high-income countries have a more substantial body of TBI research, including numerous RCTs focusing on various aspects of TBI management. As we know that the CRASH-3 trial, just an example, the effect of tranexamic acid in TBI patients included significant participation from both LMICs and high-income countries. And from these numbers, we can see that where the the RCTs are joined by lower and middle income countries, the numbers are very, very high in those trials, and they become very significant and they become very important. There are many challenges, of course, for lower and middle income countries, and mostly the low resource settings have lacked dedicated funding streams for clinical research, resulting in a dependence on external sources. And this financial constraint hampers the initiation and sustainability of RCTs. Also, to try and organize the ethical concerns in emergency scenarios like traumatic brain injuries, obtaining informed consent can be challenging, especially when patients are incapacitated and legal frameworks for surrogate consent are underdeveloped, and also that people's understanding about these issues is very limited. So naturally ensuring clinical ethical standards without delaying critical interventions require careful navigation. As we said, infrastructure and healthcare disparities, many low resource setting countries face shortages of trained research personnel and lack essential infrastructure such as advanced neuroimaging facilities and intensive care units. And these deficiencies impede the consistent implementation of standardized treatment protocols necessary for RCTs. We also noticed that to set up a clinical trial unit, which is very important, can become very frustrating and very difficult as well. Just an example where a survey was conducted regarding ICP monitoring for severe TBI between high-income countries and lower and middle-income countries. Only 48% of respondents from LMICs had training on ICP use, compared to 96%, and the main barrier was cost availability, reflecting the broader resource constraints. You may all have read this paper from Colombia by Idris Rubiano regarding the beyond one option for the treatment of traumatic brain injury, a stratified protocol, where they have been talking about developing context-appropriate TBI management protocols in LMICs. This initiative necessitates adapting treatment guidelines to align with specific resource availability and constraints of LMICs. And of course, we wrote a commentary on that, from standard-driven protocols to resource-driven guidelines for neurotrauma management in low and middle-income countries. Presently, this bootstrap document has been tested in Colombia, and it is being held by the NIHR group from Cambridge University, and they're working on that. Then more challenges are lack of follow-up mechanisms for patients. That's a very, very big problem. Maintaining long-term follow-up with TBI patients is often hindered by inadequate healthcare infrastructure and limited patient tracking systems, leading to challenges in data collection, outcome assessment. You must all have come across this consensus statement on role of decompressive craniectomy in the management of TBIs in LMICs, and they said that the result of DECRA and rescue ICP are not generalizable to conditions in LMICs, and as such cannot change clinical practice in these areas. And that we recognize and support that decisions about decompressive craniectomies must be made in context of local knowledge of access to medical resources, capacity for long-term care, and cultural beliefs. And as you know that sometimes in the lower and middle income countries, something which is called preventive decompressive craniectomies are done because they do not have availability of repeated CT scans, or they do not have the availability of ICP monitoring. So looking at the scan there and then, it is decided that maybe it is better to do a decompressive craniectomy, which may result in, of course, having many more decompressive craniectomies than may be actually required in comparing them with high-income countries. There are many opportunities for improvement in RCTs application in lower and middle income countries by improving the design and implementation, by capacity building, by collaboration and partnerships, by community involvement, and of course by innovative approaches. So to try and see whether we can modify these trial designs without compromising the trial's integrity and address variability in patient population and resource availability by making them contextually relevant. So I think it will be very important when RCT is being conducted to sit down with the departments from the lower and middle income countries to see how they can be better managed. And then having cluster RCTs involving randomized groups of clusters, hospitals, and communities rather than individuals. And it would be useful in LMICs to evaluate interventions at the community or institutional level, optimizing resource utilization. Then training local research healthcare professionals by implementing comprehensive training programs to enhance research skills and clinical expertise. It's very important to understand that the lower and middle income countries, trainees, young neurosurgeons, young doctors do not have that much training in doing research. Only now, slowly, because of so much interaction with international collaborators, this thing is coming on, and they're improving in that. And the fact is that you can see in all the journals the number of articles coming out from resource limited countries. And then to empower local professionals to ensure sustainability and relevance of research initiatives. WHO has talked about clinical research and development fellowship programs focusing on strengthening clinical research capacity in LMICs. And then investing in facilities, equipment, and systems required for conducting quality trials is very important as well. Developing partnerships with academic institutions to share expertise, resource, and best practices to bridge knowledge gaps and provide financial and technical support. A very interesting, important is the GEO-TBI registry, which is being worked worldwide and is doing a lot of work in understanding of the TBI presentations, interventions, and short-term outcomes. And you know that the World Health Assembly passed a resolution strengthening clinical trials to provide high-quality evidence on health interventions and to improve research quality and coordination in May 2023. I think the pharmaceutical manufacturers and associations are working on that, and we hope that the neurosurgical community will also look at that to develop more collaborations and partnerships. And again, I stress when the RCT is being designed to take into account the problems facing by the resource-limited countries. What we are doing here is that we are engaging communities to ensure cultural relevance and acceptability, and we are building families and communities trust to improve recruitment and retention in trials, because culturally they are very worried, and we have made some videos also regarding that to try and explain to people why are these trials important and to try and take them on board by getting discussions with them regularly. And then, of course, using telehealth and other examples, and then integrating your registries like the GEO-TBI and our neurotrauma registry has also made great help significance. If you look at the success, the CRASH trial, the corticosteroid randomization after significant head injury, had the largest number of patients, and they were big numbers from LMICs like Pakistan, more than 4,500 patients, which showed that the feasibility of conducting large-scale trials in resource-limited settings is when adequately supported. You all know about the STITCH trials, which again were worked with through LMICs, and I want to focus on this very important thing that one of the trials had to be stopped because of the number of patients were not enough in UK, and that's why it was not funded anymore. So again, it's important to make sure when a trial is being conducted that it should show that it should be both from lower middle income countries as well as high income countries to get the proper results. We all know about the hinge craniotomy studies, which are now being conducted. Again, hinge craniotomy is a cost-effective innovation alternative to decompressive craniectomies and requires few resources. And as you know, that a study was conducted now, another one is being conducted in India regarding that, and they are collecting big numbers on that. So in conclusion, limited funding, infrastructure disparities, lack of training, and ethical changes hinder RCT implementation. We need to strengthen local healthcare infrastructure to support high-quality trials, build research capacity through training and education of local professionals, develop funding mechanisms tailored to the unique needs of LMICs, promote international collaboration to share expertise and resources, encourage community and families' involvement in technology integration to advance culturally relevant and impactful TBI RCTs in LMICs. One such example how to gather more information is we are working with the help of NIHR, the Canadian Brain Injury Consortium, the G4 Alliance to make TBI a notifiable condition through a resolution from the World Health Assembly so that more data can be collected regarding this. And of course, we developed the comprehensive policy recommendations for head and spine injury care in LMICs with the help of the program in global surgery and social change from Harvard. So I think it's very important. And I would like to invite you to the Asian Congress of Neurosurgery, Young Neurosurgeons Societies World Congress on 25th to 27th November 2025 in Peshawar, Pakistan. Thank you very much.
Thank you so much for this very interesting presentation. There were a couple of questions already in the chat. For instance, by Nikat Ahmad, in which conditions do you recommend a standard protocol for preventive decompressive craniectomy?
Yes, so many different centers have got different viewpoints, but I think it depends on the effacement of basal cisterns, the midline shift, and the low GCS. And of course, in places where it's very difficult to get repeated CT scans and also difficult to monitor Glasgow Coma score and difficult to access to theater. So it's better, and it is being practiced. It is not acknowledged, but it is practiced very regularly in LMICs on that. So I think every department will have to make their own protocol regarding that. But I think it depends on the GCS, the midline shift, and the effacement of basal cisterns. Thank you.
Okay, thank you. And there's another one by Yusiakimi Udbase Mokumo. What is known if there is a significant difference in outcome in high-income countries versus low and middle-income countries?
Oh yes, I think the most important thing which was noticed, and I'm sure you know that there was a study between, I think it was United States and India, where the immediate outcome score at GUS was nearly same, but 6 months GUS was totally different because of lack of rehabilitation services present in and not present in lower and middle income countries, and the GUS was much significantly different between the two countries. If you look at the two consensus statements which were developed, one for decompressive craniectomy, which was done in Cambridge, I think it was 2015, and one was on cranioplasty, which was done in Naples, Napoli, in the ICRAN meeting. These issues were discussed in great detail, and that is why it was not given. It was given the name of consensus, so that we had a leeway to see how things can be done both in high-income countries and low-income countries. Thank you.
Okay, so Prof, I have a question for you, and I think it also came up from one of the colleagues. So what do you think about the application of basal cystonostomy? Because it's a controversial topic. In some part of the world, they are thinking about RCT. What do you think, or what do you advise?
Yes, I think we wrote a Myself, Hutch, and Franco wrote on it as well, and we got a bit of bad press on that as well, because I believe, and I think it's important that we must have a randomized trial. I can say, I do this and the patient get better, or I do that, the patient get better. But since so many people are doing it now, and people are reporting that the results are very good, especially in lower and middle income countries, now there is no harm in going ahead and doing a trial so that we can finish this questionable controversy once and for all, so that there is no issue of people getting upset about this or that. Thank you.
Exactly. Thank you very much.
I maybe have a question as well. Having also worked in different countries and communities, I found that obtaining informed consent in studies is sometimes different. For instance, elderly versus younger patients. I just wonder, in a population that may not be familiar with trials, randomized trials, how easy or how difficult is it to get informed consent from these people?
Thank you. So if you looked at my last few slides, we talked about community engagement initiatives. And I think that is the way to try and explain to people why are these trials important, so it becomes all inclusive. We did a couple of trials with Newcastle on the Stitch trials, and actually we did not find any difficulty in getting consent from them. I think our people are more trusting, I suppose, if you may say. But they need to be educated more and more through community engagement, so that it is not a problem. Thank you.
Okay, well, thank you so much. If do you want to announce our next speaker?
Yes, so our next speaker would be, we don't need to introduce him so much, Prof. Sarvade, and he will talk about the current guidelines and what kind of impact it has on our practice. And I would like to request the audience that, do you mind to put your question not in chat, but in Q&A? That is much easier to follow probably. So please. So Prof, it's your turn. Thank you very much.
Thank you. And I just share the, can you see my computer?
Not yet at the moment.
What about now?
We can only see you.
Okay, I will go back. What about now?
We can see the screen.
Now?
Yep, thank you. Now we can see your slide.
Okay, I refreshed. So, my topic is a large topic, and in 20 minutes, I will try only to show you some general consideration and two specific randomized trials. One which can be applied in most of the world, and another one which cannot be applied in most of the world. So why do we need high-level, methodologically correct randomized trial? This is a question that's very often they ask us. Why do we should to spend the time to produce money and efforts to have a randomized clinical trial? Well, randomized clinical trials are the basis for producing evidence-based guidelines. As you see it here, what we have learned from our American colleagues at the beginning of '95 is that grading the papers, we can grade the guidelines. If we have high-quality randomized clinical trials, we can support the guidelines of a standard level. Standard means everybody has to do it, because we have enough proof that this maneuver will work. This is a consideration about how do we use randomized clinical trial to produce guidelines. It is always in favor of good clinical practice. This is the last edition of the American guidelines, the BTF guidelines. The previous edition for ICP monitoring, the edition 3, that in the edition 4 they thought it was no more evidence-based, was very simple. Every patient who is in coma with a Glasgow coma score between 3 and 8 after resuscitation with an abnormal CT should have an ICP monitoring. I think the statement cannot be more simple than this. Updating this statement with new evidence produce another stating in the fourth guidelines treating ICP over not 20, 22, which we all know that 22 is recommended because values above are associated with increased mortality, full stop. So probably the third edition was more clear than the fourth edition. So at that point, we wrote a letter to the guidelines producing, asking them to have a look at the clinical outcome of the guidelines, not only at the methodology. And the answer was positive. They said, we don't want to rely only on methodology. We want to rely on the clinical side of our guidelines. So we need a randomized clinical trial to improve the quality of our care and to improve the outcome of our patient, possibly on a worldwide basis. We have already heard from Professor Tariq Khan that very limited number of randomized clinical trials are done in low-income countries. He showed the data about 30%. We have published less, 9%, but anyway, very limited numbers. This creates a disproportion between countries who are publishing papers but having an incidence of disease low, and countries with much more trauma and less publication. This is a paper that we published comparing publication and incidence of the disease. So you see that trauma are located mainly in the world in this area, South America, Africa, Southeast Asia, and the publication basically are located in the other part of the world. So basically, as my colleague Angelos says, guidelines are produced by high-income countries for high-income countries. Then, how can we have a randomized clinical trial which can help in our practice and possibly to be extended to the world of neurosurgeon treating trauma? I give you two examples, as I told you. The first one, where I obviously am biased because I am part of the Cambridge study, is the acute subdural hematoma management. First question, are we dealing with a common disease? Yes. In Europe, you see in red, in Europe and US, acute subdural hematoma is the first cause of intervention and surgical approach. Do we have uncertainty in managing this patient? Yes, this is an acute subdural hematoma that we operated in our institution. You see that there is a big shift, an hematoma. The surgeon on duty did not do any decompression and the patient had a good outcome. A similar case with a large acute subdural hematoma and the shift was managed with decompression. Likely, both cases went well, but there is obviously a difference in decision for similar cases. So the acute subdural hematoma trial was just to study whether the association between hematoma evacuation and decompression was producing better outcome for the patients. And as you see, this study was conducted in 40 centers in 11 countries, and many of these centers were located in 4 countries who are low middle income countries. And the first recruiting center was Bangalore, which was the first time in the history of studies for traumatic brain injury where over 40% of the study was conducted in low middle income countries. Then, as you see, what about Europe? This is an European webinar. As you see, the mean age of this patient was 48 years. The mean age we have in Europe now for our patient, you see the center TBI data is 50 years. So the age of this patient is similar to our age. And the process of randomization between hematoma evacuation plus decompression was made in the operating theater. What does it mean? That all the patients having a swelling outside the borders of the bone were not randomized, which is common sense. I cannot randomize two non-decompression patient with a large hematoma on the operating theater. So we are only talking about patients where we have uncertainty about what to do. And this is also the first study where the endpoint, the primary endpoint was Glasgow Outcome Scale at 12 months, because we know that surgical patient can improve between 6 and 12 months. So the outcome was shifted to 12 months. As you see, the groups were very balanced. 228 patients only evacuation, 222 evacuation plus decompression. The results were similar, so there was no statistically significant difference between the two groups concerning quality of life and concerning death and outcome. So the patients with acute subdural hematoma, where we are uncertain about doing a decompression or not, we can also not do the decompression. And additional surgery was performed in a subgroup of patients 1 in 7 who were not decompressed, but the patient decompressed had much more infections of the bone and of the skin. So the two groups were well balanced. Can we confirm that this data can be extended to our area, to Europe? This is a study which was published after the rescue SDH study. But as you see it here, this study, the patients were collected before. So as you see here, the study did not randomize as the rescue SDH. Anyway, the study evaluated a group of patients with acute subdural hematoma who were decompressed in Europe, and the group of patients in Europe which were only operated and hematoma evacuated. And basically the same as the rescue SDH. The functional outcome here is at 6 months. There are big differences between centers. There are centers doing more decompression and centers doing less decompression. And as you see, this difference is so high that the same patient can have twice the possibility to be operated in one center than in the other. So there are big variations in Europe. But the center preference, this was a surprise, did not associate with any better outcome. So what we realize is that probably the operation that we were doing or not was not influential on the outcome. And luckily, the results were very similar to the result of the rescue SDH. So this study is parallel to the rescue SDH, is done only in Europe and shows that the data are reliable. So the primary decompression can be associated with hematoma evacuation or not in the cases in which there is not a big swelling of the brain. So we have a confirmation. We have another study that I want to show you that cannot be applied by us in Europe, and I believe by probably 80% of the world, which is a study on the middle meningeal artery embolization for chronic subdural hematoma. So we know that the pathophysiology is that the external membrane is full of angiogenic factor produced by new capillaries. And we have, in the pathophysiology, we have seen that if we embolize the middle meningeal artery in patients with chronic subdural hematoma, we can avoid these angiogenic factors to be released. So we can cure, in a way, the production of a subdural hematoma. That's a strange story, because only in 2024, as I have shown you, in 10 years in decompression, we had only 3 randomized clinical trials. Here we have 3 trials published in the same year. One from US and France, but the French investigators are all neuroradiologists. One from China, and another one entirely done in US, the 3 trials. The Embolize trial is the one I want to speak with you in the perspective of telling you how it's difficult to adopt guidelines and clinical trials done in a different environment. This is a prospective, very well conducted trial of embolizing each patient with operated for chronic subdural hematoma. So all patients had a surgical evacuation by Burrows. A group of patients had the treatment group had the Burrow evacuation plus embolization. The second group had the Burrow evacuation plus only Burrow evacuation. So it's plus or minus, but all patients were operated. Which are the results? The hematoma recurrence, which was one of the endpoints, is more in the group of patients who did not do embolization. The mortality, it's not statistically significant different, but is a bit more in the treatment group. The neurological deterioration at 90 days was not statistically different, but we had a 2% adverse event, brain infarction, in the group of patients with embolization. If we do the calculation of the number needed to treat the patients, we realize that we need 14 patients to be embolized to avoid 1 patient to have a recurrence. If we insert in the calculation the 2% of the patient who had a stroke, then this difference it's even half. So we need 28 patients to show efficacy. But this is what has been published by many American newspapers. This is released to the newspapers. We have a new standard for care of the most common neurosurgical disease. The new standard of care is embolize everyone, embolize all the patients, and we will see a difference. So can we say that this study can be applied in the world and in Europe? We have to consider 2 issues. One is the conflict of interest. You see the number of authors in this paper is over 25. Each of them has at least 5 instances declared of industrial involvement. So there is a big, let's say, probably also good industrial device inclusion in this study. And the other is the cost-benefit ratio. In US, we can have a study with producing a guidelines or a suggestion. Then there is always a limit. The limit is the insurance. If the insurance does not pay, the study is not there. So the patient will never be embolized. In Europe, unfortunately, we have to take care of all these patients. So in 90% of Europe, we should consider that if we want to embolize any chronic subdural hematoma who has to be treated, we should centralize all of them to centers where we are able to centralize to cure the patient. And also, we need to deal with numbers who are very high. Then I want to say you some few words about the other two studies. The other two studies are completely different. The entry criteria is not the operation, meaning operation plus embolization, operation only, like embolites. These two studies are left, the indication for surgery are left to the neurosurgeons. If the patient is a surgical approach or not, it doesn't matter, is randomized to operation or non-operation plus embolization or only operation or non-operation. So it's different. The STEM study, which is an American study, show a difference again in favor of embolization as the recurrence rate of chronic subdural hematoma. But as you see, this is a very thoughtful consideration done by your European group last month in brain and spine. As you see, this study includes a group of patients where probably surgery is not necessary, a group of patients who can be cured by just watching them. And the Chinese trial, which again a trial of patients either operated or not, all of them embolized or not, so it's a 4-level randomization. It's showing that there is no difference in recurrence rate because between the group of patients who were embolized and the group of patients who were not embolized. The difference with the embolized study is that the incidence of adverse event differently from that study is less in patient embolized. So here again is the consideration. And also the rate of recurrence was very low as compared to the literature published. So in conclusion, for a randomized clinical trial about embolization, we can say, first, if we wish to do a pooling analysis, it's very difficult to pooling together the 3 studies because the entry criteria identify different population. Probably embolization may prevent hematoma progression and the recurrence rate, probably at the price of treating patients who don't need it. Unfortunately, we have not demonstration of better clinical outcome, and there is no risk benefit. So what to do? This is a multidisciplinary, just finished now, IFTI, a multidisciplinary consensus conference, which was just published, which was composed by representatives of many Europeans, neuroradiologists, neurosurgeons, neurologists, many European society. And as you see, this consensus before meeting the experts revised all the published literature until 23, and they went up with some consideration that the standalone, like they have done in this study, treatment was for embolization should be reserved to patients who cannot stop anticoagulopathy and antithrombotic therapy because of medical condition, maybe can be used where surgery is prevented by a very high risk of complication and can be used as adjunct to surgery when we reoperate patient. So it's much more common sense based by the experts and by the literature. So in conclusion, application of well-conducted clinical trials in areas with different socioeconomic environments and available research may be extremely difficult. consensus conference with an hybrid system of literature review and expert opinions may help. There is a need for a more global approach to guidelines production and application, and I would say that in many places where we produce guidelines, already this concept is in place. Thank you.
Thank you very much, Professor Servade, for these wise words. I'm checking the question and answer, but I don't see any new question, but I have a question myself. So you rightfully point at potential problems with generalizability that can have different origins, and also sometimes studies that are biased, and that the limitations are so pronounced that we need consensus to actually accommodate for that. Now, there are studies that are totally acceptable and that have very little limitations and that are generalizable, and then still there's problems with implementation because of our colleagues sometimes being reluctant to change habits or to go away from the way they were trained. I mean, when we do all the effort to produce evidence, how should we tackle the problem of making it really land with everybody?
Well, you're right. One way we produce evidence, we have three arms where we should make our colleagues to use what we produce. One is the good clinical study, as we showed. The second one is the applicability of the study to your situation. And the third one, which is the one you mentioned, is the period of the time where we are. Sometimes we are too early or too late. Our colleagues will not accept what it is evident. We have many, I don't tell you, you know, but we have many experience in the story of medicine of very good practice, which were adopted 30 years later, not when they were produced. So we have to convince our colleagues about the prejudice. And sometimes, as you say, we are all surgeons. We know what to do, basically, and we have difficulties to change. But when one study is produced in one area, then in another, and the result always in the same result, maybe it's easier to convince.
So, Prof, can I ask you a question?
Yes, go.
So my question is that, what do you think the young neurosurgeons or trainees all over the world, how should they interpret the findings of different consensus? Because the level of evidence is still poor.
Well, I mean, the EANS, and here we have Peter with us and Bart. The EANS has supported recently many consensus conferences, and I believe that the consensus, having the expert from the country where the disease is endemic, are more, at the moment, are more adaptable from different areas than possibly only randomized clinical studies. But what I advise the colleagues is not to take what has been published as a golden Bible, because sometimes you have when you are young, you are enthusiastic, you review papers and say, I can do it. Before you say, I can do it, as I told you, before you can say, I can do it, you have to see where you are, because as I told you, our American colleagues will never tell you that there is always a gate in US, because if you don't have the insurance, we can talk about embolizing everything, but they will not be embolized. So we know that you have to know exactly where the study came from and how you can use it in your own situation.
Thank you very much, Prof.
Sorry,
Well, I see comments to but there are more comments than questions, I think.
Yeah. And we have a question from one of my colleagues. He asked, how could we include more LMICs in the RCTs? How could we develop their infrastructure and how could we inspire them to get it done?
Well, after me, Peter will speak. So he has done it, so he knows how to do it. But I think there is a misunderstanding about the capacity of many countries to take part to this study. We are overemphasizing difficulties that my experience, and it is that when we start working together and we start discussing, then we see that there are more similarities than difficulties. So I believe we have, Peter has shown in the SDH study that we can do it with high quality and good quality data. Tariq.
Yeah, thank you. May I just say something? I believe that, can you hear me?
Yeah, we can hear you.
Yes.
I believe that since the start of the global neurosurgery, which Franco, thank you very much, who started the Global Neurosurgery Committee of the WFNS. I think since then, because of the concept of the global neurosurgery, a lot of people are interacting with each other. A lot of different hospitals, neurosurgical departments are interacting with each other. And I think this is a great way to go. And I think many more RCTs will come out of this collaboration. Thank you.
Thank you very much. So, Bart, we don't have more questions. Probably you could go forward.
Yeah, so I think we can announce our last speaker, and it's my pleasure to announce Professor Peter Hutchinson from Cambridge, how to implement or how to include RCTs in guidelines.
Great, thanks very much. Can you hear me okay?
Yeah, we can hear you well.
Yeah, we can. Yeah.
Ifti Bart, friends and colleagues globally, thank you very much for the invitation to contribute to the webinar and to follow on from the great talks from Tariq and Franco. So my title and instructions were to present a talk on RCTs on TBI, impact on guidelines and lessons learned. If you look at the portfolio of RCTs in traumatic brain injury, broadly speaking, they fall into either medical interventions and surgical interventions. Medical interventions tend to be pharmacological, so drug, neuroprotective agents, and other medical interventions, hypothermia and other therapies. And then the surgical interventions have tended to be either an internal decompression, as per the Stitch study that Tariq mentioned, or external decompressions, the rescue and DECRA studies that Franco has already alluded to. If we look at the information that we've gained from RCTs of pharmacological treatments in traumatic brain injury, there have been many agents that have been successful in the laboratory, animal and scientific studies, but sadly, very few of these, if any, have percolated through to benefit in the clinical arena, perhaps with the possible exception of tranexamic acid, or you could argue that that's not really a neuroprotective agent. It is an agent which is really addressed to reduce the amount of hemorrhage. So if you look at these RCTs and you're critical about them, why have they failed? Well, there's uncertainty about the robustness of the preclinical data. So maybe the laboratory studies perhaps did not replicate the clinical situation. Often phase 2 trials were inconclusive. Despite that, we went on to phase 3 trials. There's concern about when the drug was delivered, the unclear therapeutic window. Was the drug given too late? Perhaps the trial design was inadequate or poorly analyzed. Did the agent actually get into the brain, cross the blood-brain barrier? Some of the studies had a heterogeneous population, so maybe some of these drugs were in contusional injury, but not in extraaxial hematomas. And also there were a number of concerns in terms of how outcome was assessed. The other concept, which is a sort of personal hobby horse of mine, is that this is complicated. Brain metabolism is very, very complicated. There are multiple pathways involved and multiple disruptions. This is a complicated ecosystem, not dissimilar to the map of an underground system for a city. What I'm trying to get across is if you are trying to just intercept one pathway, one line, then you will not protect the whole system going forwards. If we move on to the surgical trials, so these fall broadly into the internal decompressions. So Tarek's already mentioned the Stitch trial. That was terminated prematurely. Funding was withdrawn. This was in an era when the UK funding agencies had very little funding available to be spent outside the United Kingdom. Fortunately, that has changed, but it was a pity that Stitch was terminated early. As you recall, it showed reduced mortality, but wasn't powered to give an indication of quality of survival and disability in those who survived. We've talked several times about the decompressive craniectomy studies, but I just want to focus on how these studies can begin now to inform the guidelines and impact on our practice. And when Rescue ICP was initially presented, I think we presented the results, they were displayed, and people came up with their own decisions in terms of how to manage patients going forwards. I think the secondary analysis of Rescue ICP more recently published is actually very powerful. This was led by Angelos Kolios, and the 24-month data begins to show marked improvement in these patients across time. And what we've learned is, Frank has already alluded to this, that 6 months is probably too early, 12 months is also probably too early. But to assess outcome out of these RCTs, you're really beginning to have to look out to at least 2 years. And you can see that red arrow. I mean, Rescue ICP, I think, was controversial because of the dichotomization between upper and lower severe disability. We chose that because these are the most severely injured patients. But at this 2-year mark, you're beginning to see quite a marked increase in quality of survival in the surgical survivors in terms of dichotomization at the level of severe versus moderate disability. These are the brown versus the blue here. So we're beginning to see that at 2 years, of the 21 extra survivors from traumatic brain injury, about 6 of these are dependent, but about 7 now are independent at home, and 8 are actually independent outside the home. So I think there is perhaps increased evidence for decompressive craniectomy when you follow the patients longer. And in terms of how that has perhaps helped inform the guidelines, so the TreeKit guidelines that we recently contributed to, that was led by Jeff Manley, have a number of cartoons or diagrams to help guide our management. So this is a diffuse injury, initial medical management, ICP control, continued medical management, ICP uncontrolled. At this point, Rescue ICP and the 24-month data to consider a secondary decompressive craniectomy. Franco's already talked about rescue acute subdural. I just wanted to highlight a couple of other aspects from this trial. The reason for doing it, often the guidelines can be very, very helpful in helping us design our trials. So this was the guidance out of TQIP and the Brain Trauma Foundation. I think Greg Holick and Jan Gajar are actually on the list of attendees. The guidelines out of the Brain Trauma Foundation have been very helpful, not only in demonstrating the currently available evidence, but informing us as to what trials we should be doing in the future. So they have said that a paucity of literature currently informs the practice of leaving the bone flap out following initial surgery to evacuate an intracranial mass lesion. So the guidelines with research recommendations can then lead on to answering these questions. So as Franco says, this was basically decompressive craniectomy, bone off or bone back. The results showed similar outcomes between the craniotomy, bone back, and decompressive craniectomy, bone out. And the implications beyond the results, it would be common sense that if the results are the same, whether you put the bone back or leave it out, then put the bone back, because you don't need to then go on and do a subsequent cranioplasty. But the caveat to that is that patients in rescue acute subdural who had the bone back were managed predominantly on intensive care units, and that applied to whether they were in high-income countries or the many patients that were very successfully recruited in the Indian Centre of Bangalore. As Franco says, many patients were randomized in low middle income countries. If intensive care is not available to manage raised ICP medically when the bone has been put back, then these findings may not be relevant. So the caveat for rescue acute subdural is resource limited or military settings. A preemptive craniectomy may be the way forwards because you cannot manage ICP medically in the absence of these facilities. So I think that's an important message from rescue acute subdural. And again, in the TCAT guidelines, so this was figure 3 in the surgical guidelines, the initial surgical management pathway, where we have an acute subdural, a surgical intervention, trauma craniotomy, bone can be replaced without compressing the brain, bone back, and bone cannot be replaced without compressing the brain, bone out. So it's a relatively simple message, but it does show how the RCT has moved through into the guidelines. And then if we take that beyond the figures, these TCAT guidelines came out last year, and I think it has been helpful for the RCTs to provide some of the key points. So these are the key points currently in the TCAT guidelines: to evacuate a large traumatic hematoma before neurological deterioration develops, irrespective of the GCS score. A lot of that is common sense and has not actually been guided by RCTs. But rescue acute subdural has taught us for evacuation of acute subdural, perform a large trauma craniotomy to achieve optimal damage control and provide the option for a primary decompressive craniectomy. The bone can be left out. But if the bone can be replaced without compressing the brain, then the bone may be placed back, and we would advocate doing that, providing on the availability of ICP monitoring and ICU facilities, as I've already mentioned. But leave the bone out if you're replacing it, could cause brain compression. And then the 24-month data from Rescue ICP, I think, has now shown us that secondary decompressive craniectomy is effective in controlling ICP with evidence for improving long-term outcome. But again, remember, there is still a cohort of patients following a decompressive craniectomy who are in the poor prognostic categories of vegetative state and lower severe disability. So we've come up with this concept of, can we actually use the trials to influence practice? So I call this the 3 Ps. This is the publication. So in a journal, RCT is published. It then needs to go through to policy, where it influences the guidelines, for example, the Brain Trauma Foundation guidelines, the TCAT guidelines. But then we also need to look back and see where the practice has actually changed. So has the trial changed the guidelines, but have the guidelines changed practice? And this study performed by Harry Mees. So this is a UK study showing an increased incidence of decompressive craniectomy being performed and cranioplasty being performed following publication of this and other trials. And in this short period, there was a 14% increase in the uptake of decompressive craniectomy. So huge credit again to the Brain Trauma Foundation and colleagues for the guidelines. As Franco showed, the 4th edition was the latest, but there have been a number of live updates. And I think what the Brain Trauma Foundation and other guidelines have illustrated is, this talk is about RCTs, but actually there have been relatively few of them that have helped influence the guidelines. So one of the take-home messages, a lot of the recommendations are based on other types of evidence, class 2 and class 3 studies. And I think that would encourage us, hopefully, to undertake more RCTs to improve the quality of the evidence. Again, Franco showed this. So these updated treatment recommendations from the Brain Trauma Foundation are predominantly based on level 2A, level 3B, and even level 3 evidence. And in fact, in the update, the level 1 evidence relates to the RCT, the CRASH trial. The use of steroids is not recommended for improving outcome or reducing ICP, and high-dose methylprednisolone is associated with increased mortality and is contraindicated. But there is, reasonable evidence for some of these other therapies. Other recommendations, again, a combination of level 2A and level 3 evidence. There is this level 2A, present time insufficient evidence to recommending Keppra compared to phenytoin regarding efficacy in preventing early post-traumatic seizures and toxicity. That has incentivized us to undertake a randomized trial called MAST, which is a randomized trial of the use of anticonvulsants in traumatic brain injury. two parts. Firstly, prophylaxis. So should we use prophylactic anticonvulsants? And secondly, duration of treatment. If you sustain a post-traumatic seizure, how long should you give an anticonvulsant agent for? So that's the master trial currently recruiting. Frank again has already talked about ICP monitoring. This is generally around the level 2B and 3. Franco has already talked and very clearly about the controversies in terms of middle meningeal artery embolization, but there have been, I think, more clear-cut answers in the management of patients with chronic subdural hematoma. So the two papers that were published relating to RCTs of dexamethasone versus surgery for chronic subdural hematoma. So these were looked at by the ICENI guidelines. So this is the ICENI working group, the Improving Care in Elderly Neurosurgery Initiative, predominantly looking at chronic subdurals, produced guidelines on the management of chronic subdural hematoma, have adopted the findings of the trials with adjuvant therapy recommendation number A. Corticosteroids should not be used to treat symptomatic chronic subdural hematomas, either for non-operative management or as an adjunct to operative management. And I think the same applies to the DRAIN study. So Tom Santaris's DRAIN trial, again, published, showed a marked reduction in recurrence for patients who'd had a DRAIN from about 22% to 9%. But again, it's no good just producing the trial if practice doesn't change. So this is an example, the study by Taylor et al., where they actually audited the use of drains, increased initially, and then drain utilization was increased to 75%. And I think drains have now become a standard of care. So again, if you go back to the ICENI guidelines, the RCT has informed the guidelines surgery should include the placement of a temporary drain, either subdural or subgaleal, where it is safe to do so. The final part and the final slide is to talk about lessons learned. That was the third part of the title. So what have we learned by conducting these RCTs? Firstly, they're challenging to deliver. There are many challenges, particularly in terms of recruitment. We know they often take many years. They have focused on high-income countries. Again, that's something that we're trying to change. The UK funding agency is now very much in favour of funding RCTs in low-middle-income countries. The MAST trial is also going to recruit in India. There is a trial of hypertonic saline versus mannitol that is going to be recruiting in Brazil. So I think that is changing. In terms of medical management, TBI is complex. Will one trial of one drug ever be effective? Should we continue to pursue RCTs of single drugs, or is that futile and maybe we should look at other approaches? We need to get smarter about how we design the trials, inclusion-exclusion criteria. We know that some of the decompressive craniectomy trials show we need to look at longer-term outcome, but we probably need to look at better outcome measures beyond the extended Glasgow outcome score. That is not granular enough to pick up some of the nuances, particularly in those patients who are perceived to be upper moderate disability and lower good recovery. Perhaps some neuropsychological endpoints would be better. For the mechanistic studies, as well as outcome, we should be looking at surrogate endpoints. This has already been discussed earlier. Now, often these trials are ethically approved, relatively straightforward in some countries, but the regulations, the contracting arrangements, the bureaucracy, the sponsorship, the insurance is really holding us back. And we're working with Tony Fagagi to try and break down these barriers. We need to try and move this bureaucratic barriers. And what we've learned is if you're going to increase recruitment, you need to increase centres. To increase centres, you need to get more countries engaged. Other challenges relate to uncertainty. We know that many people have strong ideas about what is the best treatment. Perhaps it's good to try and put your own ideas aside, show equipoise, and actually randomize patients. And then finally, it is really important to emphasize it is no good just publishing in the journal. That is not the end of the journey. If you're going to do that, you've got to make sure that what you do gets through to policy, whether it's guidelines, Brain Trauma Foundation, TKIP, other guidelines. But then it's very important to also audit practice beyond that to show that the trial influenced the guidelines, but then that actually did change people's decision making. It's to complete this cycle, I think is really, really important. I'd like to acknowledge many people involved in our trials, trainees both in the UK and beyond in delivering these trials. The NIHR, so the UK National Institute for Health Research, now has quite a comprehensive global health program. Tarek's already discussed that. And this has been really helpful in getting RCTs in low and middle income countries. My colleagues in Cambridge, and that's my email address if any questions. Thank you very much for the invitation to speak. I'm really happy to answer questions now or by email later.
Thank you very much, Hutch. It's a great talk. We don't have any specific question, but could I please ask you something?
Yeah, please do.
Okay, so when we are talking about the applications of RCTs, do you think, for example, in rescue ICP, we know that 24 months patient, the surgical arm is doing better compared to medical arm. But how many patients all over the world could go through long-term rehabilitation, having a shunt, cranioplasty? So when we talk about the applications, do you think in future, should we also, when we publish the results, should we also have a section that how it could be implemented in LMICs, or what are your thoughts?
Yeah, so that's absolutely right. And what came after Rescue ICP, and I haven't discussed it in the interest of time, is the consensus statement that Tarek mentioned. 2015 was published in 2017. That we were very keen that the consensus statement had a separate section on low and middle income countries. So what's come out of that is there's been a number of initiatives, two in particular. The first is a program to improve rehabilitation. So we're working with our collaborators in India, where we are trying to introduce family-directed rehabilitation, teaching families rehabilitation strategies to undertake rehabilitation. So that's one concept. And the other, of course, and this has already been discussed too, is to avoid the cranioplasty. Is hinge craniotomy an acceptable alternative to decompressive craniectomy to avoid having to go down the cranioplasty route? I think Tarek's got his hand up.
Yeah, thanks, Harsh. Yes, I think this is a very important point which you talked about, Harsh, regarding rehabilitation by family members. There was a paper from Aga Khan University, Karachi, Pakistan, regarding giving formal training to the immediate caregivers so that they can, when they go home, the patient, because there's no rehab services to do that. And I think that's a great project which is being done there, and is being practiced here now as well in our hospital as well. Thank you.
But if the rehabilitation and lack of access is not only a low and middle income country issue, if you look in Europe, there's probably less than 20% of people are getting the rehabilitation that they should be getting. So I don't think this is just directed at low and middle income countries. This is a global issue.
And we have a question from one of our colleagues from LMICs. The question was that if they would like to participate in the RCTs, could the global neurotrauma or global neurosurgery could help them, or how should they proceed for that?
Yeah, we'd be absolutely delighted. You know, please contact us. We do have a number of trials. Myself, Tarek, Franco, you know, we're all involved in these trials. So if you're interested in joining a trial or creating a trial, then please let us know. As I said, one of the big barriers is bureaucracy and sponsorship. So for example, the MAST trial, so this is the anticonvulsant trial, which we're running out of Cambridge, because it's a drug trial, a UK university is not able to sponsor that drug trial in another country. So there was a potential problem that we may not be able to do MAST. How do you overcome that? Well, you get it sponsored from the parent country. So in effect, the way to often do this is to run parallel trials with the same protocol, exactly the same inclusion-exclusion criteria. The funding we can direct. In effect, the CRF is the same. The data will be the same, but we just have to find these little tricks to get over some of the bureaucratic hurdles.
Yeah, and just a final question probably. So it came in a neurosurgical meeting, in a Young Neurosurgical Society meeting. The question was that in many academic centers, we are still pushing therapeutic hypothermia. We know that there are complications. And so what did they say that should we really push our patient too much at that level when we have different complications, and some of them are even included in different trials? So what do you think about this type of practice?
So did you say therapeutic hypothermia?
Yes.
Yeah. So there's a number of interventions in medicine, neurosurgery, brain injury, where the intervention is probably effective in determining what it should be doing. And hypothermia is a classic example of that because it does reduce intracranial pressure.
Yes. Yeah.
I think we all know that. The problem, of course, is that the side effects outweigh the benefit. Franco talked about stroke following middle meningeal artery embolization. So if you're going to undertake this intervention, you need to be really careful to manage the side effects. Now, you could argue, and I think if you look at some of the centers in the hypothermia studies, providing you get on top of the complications and you manage the clotting and you manage the infections, hypothermia could be very effective. So I think you need to look very carefully when you're designing these trials, not only at the efficacy of the intervention, but the safety profile as well. And if you can mitigate the harm that this intervention can cause, it could still be very, very effective.
Exactly.
Yeah.
Yes, I completely agree with you. Do we have any more questions? Prof, you want to tell something? Professor Vaday, do you have any question?
No, I think I support what Peter said. It's a very important concept. When we organize the randomized clinical trial, we know about the side effects, and we know about how that we will have complication, not in a randomized, it's our life. We are neurosurgeons, we live with complications. Very often we pick up the centers which can run the trial, but have a very low experience with the complication. And this makes a problem to the whole trial. This example of hypothermia was really one example. And there is what we have seen in European studies, that there are huge disparities between the various centers. So if you believe that the ICU European study on COVID pneumonia showed that the first determinant of outcome is where you are, that this is the first determinant of outcome. So we have to consider the different possibility of treating patients and stratify the centers, as Peter said. That's a very important concept, dealing with the study, but dealing also with the complication.
Exactly. So I think we have learned a lot today, and it has been a great time altogether. So thank you very much, Professor Vaday. Thank you, Prof. Khan, and Hutch. Thank you very much for excellent talk. And we would like to also thank all the participants and the EANS office. Probably we'll see us together soon. Take care.
Thanks so much.
Thank you.
Thanks, everybody.
Bye.
Have a good evening.
Bye.
Bye. Bye. Bye. Bye.